Hello everyone, my name is Hafsa Suwidian Dias, and in this video I will talk about the resume of the third week lecture Cleflip and Palate. We got 5 topics from this week. First is talk about bilateral cleft lip repair. Cleft lip is an aesthetically unpleasant congenital orofacial deformity, misnomer as effects of loose lip and nose prepalate, commonest major facial anomaly. Its treatment dates back to ancient times. Early techniques involve a straight line closure. Presently, the differential rearrangement of the muscle components to correct their insertion and reorient the muscle fiber is advocated. The least common type of isolated cleft lip is bilateral isolated cleft lip. In bilateral, incomplete nasal symmetry often preserved. Prolabium is shorted also. Most common method repair is Mulligan's repair and Manchester repair. The challenge in performing bilateral cleft lip repair, constructing the nasolabial complex in 3 dimensions, anticipating 4-dimensional change of growth and distortion, amino-nasolabial asymmetry will become more obvious in time, difficult to make adjustment after the primary repair. Success in cleft lip and palate repair hing on proper and adequate dissection. Straight line repair first, acceptable in microfoam repairs. Next is adequacy of prolabium must be ensured. Next, cupid bow peak and tubercle must be acceptable, and last is muscle continuity ensured. And in topic 2 is talk about unilateral cleft lip repair. Anatomy consideration abnormalities. Lip is about abnormal attachment of orbicularis oris, cupid bows, vermilion, and philtrum. Then in the nose is alarnasi, nasal floor, and nasal bridge. Alveolus and others. Others is maxillary hypoplasia. Goals of repair. First, to restore lip continuity, thin muscle mucosa, restore nasal floor integrity, achieve lip symmetry, achieve nasal symmetry, and conceal or minimize scar. Timing of repair at the age of 3 months. Child should have weighed more than 4.5 kilogram, no anemia, and hemogram more than 10 gram. Surgical approach, several and wide range of techniques. Approach should be flexible, simple as possible, easy to teach to trainees. Most commonly used is Millard rotation. Advancement repair technique may need to be modified even during the surgery. Good to be proficient at a particular approach that works for you. Complication and outcomes that can be happen. Notching, labial symmetry, one complication. There are partial dehiscence and complete dehiscence. Oronasal fistula, scar complication, uh, bunch up orbicularis oris, asymmetric capit's bow and vermilion border, and asymmetric vermilion. Some secondary surgeries may be required if some complication happen. There are lip adjustment, alveolus, and nasal deformity. And in topic 3, we got know about cleft palate repair. Cleft palate is a failure of fusion of palatal salve. Palatal fusion in 5 until 6 weeks of intrauterine life. Timing for surgical correction. Cleft palate alone, palate repair at 9 until 18 months. Cleft lip and palate repair at 3 until 6 months. So palate repair in 6 months later. Priorities palate repair should close the defect without a fistula and with minimal scarring, should make the palate work, restore anatomy and mobility for speech, and minimize sequela. The greater palatal artery is the most important thing to be lifted along in oral mucoperiosteum procedure. When midline incision is insufficient, we can do the lateral release incision or Langenberg. And if there is bleeding immediately post-operative, we should do the re-explore. And in topic 4, we got know about cleft palate repair, not suggested for patients more than 2 years because it will delay speech ability. We should pay attention to this stuff when you want to do a cleft palate surgeries. First, anesthesia can be overemphasized. The surgeon must be careful about introduction of the mouth gag for the surgery. Communication is therefore very essential and important between the surgeon and anesthetist. In this topic, we know that cleft palate repair can be a delight to carry out. Well-prepared child will lead to good outcomes, speech mainly. As you can see, there are quite a number of repair methods, and to trainees learn from your consultant and research surgeons. And in the last topic, we know about the cleft palate. In this topic, we know that knowledge of the anatomy of heart and palate is important in the repair of cleft palate and prognostic view of surgical outcome. Any method employed in the repair of cleft palate should aim to re-establish the muscular link to the soft palate to enable proper speech development, and further studies will have to be carried out in our environment on the appropriate timing of repair of cleft lid. That is all for me. Thank you so much for your attention. I would like to apologize if there is a mistake. Thank you.